Bismillahirrahmanirrahim. I will discuss endometrial hyperplasia, which is an important subject in gynecology. Our reference is the Green Top guideline elaborated by the Royal College of Obstetricians and Gynecologists of the UK, the guideline number 67, and its date was February 22nd, 2016. We start with the definition of endometrial hyperplasia. Endometrial hyperplasia is the irregular proliferation of the endometrial glands with an increase in the gland to stroma ratio when compared with proliferative endometrium. Endometrial hyperplasia is the precursor of endometrial cancer, which is the most common gynecological malignancy in the Western world. The incidence of endometrial hyperplasia is estimated to be at least 3 times more higher than endometrial cancer. The most common presentation of endometrial hyperplasia is abnormal uterine bleeding. It may be in the form of heavy menstrual bleeding, intermenstrual bleeding, irregular bleeding, unscheduled bleeding on hormone replacement therapy, or it may be a postmenopausal bleeding. The etiology of endometrial hyperplasia is the continuous estrogen unopposed by progesterone stimulation of the endometrial cells that leads to its growth by binding to the estrogen receptors in the nuclei of the endometrial cells. So the main cause behind the development of endometrial hyperplasia is the unopposed estrogen stimulation of the endometrial cells. Other elements that may be suggested to have a role in the development of endometrial hyperplasia, such as immunosuppression and infection. The risk factors for endometrial hyperplasia include increased body mass index with excessive peripheral conversion of androgens in adipose tissue to estrogen, anovulation associated with the perimenopause or the polycystic ovarian syndrome, estrogen secreting ovarian tumors such as granulosa cell tumors with up to 40% presence of endometrial hyperplasia, drug-induced endometrial hyperplasia, for example, in the use of systemic estrogen replacement therapy for long periods of use of tamoxifen as a chemotherapy for patients with breast cancer. Endometrial hyperplasia is often associated with multiple identifiable risk factors, and assessment should aim to identify and monitor these risk factors. Classifications for endometrial hyperplasia. Endometrial hyperplasia had many classifications, starting from simple hyperplasia, complex hyperplasia, simple hyperplasia with atypia, and complex hyperplasia with atypia. This WHO classification was published in 1994. The association of cytological atypia with an increased risk of endometrial cancer has been proposed or has been known since 1985. The second classification was the endometrial intraepithelial neoplasia, resembling that of the cervix, vagina, and vulva. It was elaborated since 2003, but it had not gained a popularity. The endometrial intraepithelial neoplasia diagnostic scheme comprises of 3 categories: benign endometrial hyperplasia, premalignant endometrial hyperplasia, a diagnosis of endometrial intraepithelial neoplasia based upon 5 subjective histological criteria, and a malignant a malignant category which represent endometrial cancer. Again, this classification was not popular and was not practiced by clinicians more than the other. It was the least practiced one classification. The latest and most accepted classification was suggested by the WHO revised classification in 2014. It was simply separates endometrial hyperplasia into two groups based upon presence or absence of hyperplasia. Presence or absence of atypia. So endometrial hyperplasia currently is classified into two types only: hyperplasia without atypia and hyperplasia with atypia or atypical hyperplasia. The complexity of architecture is no longer part of the classification. Complex hyperplasia is eliminated from the classification because it has a minimal clinical impact on the progress of the disease. The revised 2014 WHO classification of endometrial hyperplasia is recommended by the Royal College of Obstetricians and Gynecologists, and it is nowadays the most accepted type of classification. How to diagnose endometrial hyperplasia? Histological examination via outpatient endometrial sampling. Diagnostic hysteroscopy should be considered if biopsy failed or non-diagnostic, or endometrial hyperplasia has been diagnosed within a polyp or other discrete focal lesion during hysteroscopic diagnosis. Transvaginal ultrasound may have a role in diagnosing endometrial hyperplasia in the pre and post-menopausal women, depending on the endometrial thickness in these women. The cutoff level of endometrial hyperplasia in patient not taking tamoxifen is 5 milliliters, 5 millimeters, while the cutoff level of normal endometrial thickness in patient on tamoxifen is 11 millimeters. There is insufficient evidence evaluating CAT scan or MRI or biomarkers has aids in the management of endometrial hyperplasia, and their use is not routinely recommended. No evidence that these diagnostic tools are superior to the usual ultrasound. Management of endometrial hyperplasia, we classify patient regarding management into management of patient without atypia and management of cases with atypia. We start with management of patient with endometrial hyperplasia without atypia. Initial counseling, women should be informed that the risk of endometrial hyperplasia without atypia progressing to endometrial cancer is less than 5% over 20-year duration, and that the majority of cases of endometrial hyperplasia without atypia will regress spontaneously during the follow-up. So regression is the rule in patient without endometrial atypia. Reversible risk factors such as obesity and the use of hormone replacement therapy should be identified and addressed if possible. So if a patient with endometrial hyperplasia without atypia started to be followed up and she is obese and started to reduce her weight, and if she is on hormone replacement therapy and stopped hormone replacement therapy, the regression rate is very high without treatment. Observation alone with follow-up endometrial biopsies to ensure disease regression can be considered a method of management, especially when identifiable risk factors can be reversed, such as obesity and hormone replacement therapy. However, women should be informed that treatment with progestogens has a higher disease regression rate compared with observation alone. Medical treatment of hyperplasia without progestogen or gestogen, both continuous oral and local intrauterine levonorgestrel releasing intrauterine system are effective in achieving regression of endometrial hyperplasia without atypia. So, gestogen when given must be continuous. There is no rule for interrupted regimens in the modern gynecologic practice. And local intrauterine levonorgestrel releasing intrauterine system, for example, Myarina, is superior in the management than the oral gestogens. The levonorgestrel releasing intrauterine system should be the first line medical treatment because compared to oral progestogen, it has a higher disease regression rate with a more favorable bleeding profile and it is associated with fewer side effects. This recommendation is class A recommendation. Continuous progestogen should be used, for example, medroxyprogesterone 10 to 20 milligram per day or norethistron 10 to 15 milligram per day for women who decline the use of the intrauterine system releasing levonorgestrel. Cyclical progestogen should not be used. Cyclical progestogen should not be used. And for the third time, should not be used because they are less effective in inducing regression of endometrial hyperplasia without atypia compared with continuous oral progestogen or the levonorgestrel releasing intrauterine system. And this is a very, very strong recommendation by the RSOG. What about the duration of treatment and follow-up? Treatment with oral progestogen or the levonorgestrel IUD should be for a minimum of 6 months. Minimum of 6 months, not less than 6 months, in order to induce histological regression of endometrial hyperplasia without atypia. If adverse effects are tolerable and fertility again, if adverse effects are tolerable and fertility is not desired, women should be encouraged to retain the levonorgestrel releasing intrauterine system for up to 5 years. And this reduces the risk of relapse, especially if it alleviates abnormal uterine bleeding symptoms. Outpatient endometrial biopsy is recommended after a diagnosis of hyperplasia without atypia. Endometrial surveillance or follow-up should be arranged at a minimum of 6 month intervals. At least 2 consecutive 6 monthly negative biopsies should be obtained prior to discharge from the follow-up program. What about the endometrial office biopsy in the presence of intrauterine Mirena? There is no contraindication for endometrial biopsy in the presence of Mirena. We can obtain the endometrial office biopsy in the presence of Mirena without risk for the amount of obtained tissue or risk for the Mirena system. In women at higher risk of relapse, such as women with body mass index more than 35 or those treated with oral progestogen 6 monthly endometrial biopsies are recommended. Once two consecutive negative endometrial biopsies have been obtained, then long-term follow-up should be considered with annual every year endometrial biopsy. These patients who are at higher risk of relapse with body mass index 35 or more, or those on oral, not the intrauterine progestogen releasing system. What about the surgical management of endometrial hyperplasia without atypia? Hysterectomy should not be considered as the first line of treatment for hyperplasia without atypia, as most cases respond to progestogen. Hysterectomy is indicated in women not wanting to preserve their fertility when progression to atypical hyperplasia occurs during the follow-up, no histological regression of hyperplasia in 12-month treatment, there is relapse of endometrial hyperplasia after treatment, persistence of bleeding symptoms, the woman is not compliant on progestogen or follow-up. So, hysterectomy is not the first line of treatment. Hysterectomy is indicated in 5 types of patient. If progression to atypia, the hyperplasia without atypia converted into atypical hyperplasia during follow-up, or there is no response to progestogen, no regression in 12 months duration of treatment, or the patient treated with negative endometrial biopsies, but relapse later on, or there is no symptomatic improvement, or the woman is not compliant for the follow-up or treatment. These are indications for hysterectomy in patient with endometrial hyperplasia without atypia. If hysterectomy is indicated, postmenopausal women should be offered a bilateral salpingo-oophorectomy together with total hysterectomy. These are the postmenopausal women. For premenopausal women, the decision to remove the ovaries should be individualized. However, bilateral salpingectomy should be considered, as this may reduce the risk of future ovarian cancer, depending on the recent theory that most epithelial ovarian cancers develop from the femoral end of the ipsilateral tubes. Endometrial ablation is not recommended. Endometrial ablation is not recommended according to the recent evidence for the treatment of endometrial hyperplasia because complete endometrial destruction is not assured, resulting adhesion preclude future endometrial sampling. What about the management of endometrial hyperplasia with atypia? That's to say, atypical endometrial hyperplasia. Surgical management is the first line for treatment of endometrial hyperplasia with atypia. Laparoscopic hysterectomy for total hysterectomy is preferable to an abdominal approach, as it is associated with a shorter hospital stay, less postoperative pain, and quicker recovery. In my opinion, in Mansour University Hospital, we prefer vaginal hysterectomy in average size uterus, less than 12-week gestational size for performing total hysterectomy and adenexectomy if we prefer, and it is less costly than the laparoscopic hysterectomy and more suitable to our resources in Mansour University Hospital. No benefit from intraoperative frozen section analysis of the endometrium or routine lymphadenectomy. Postmenopausal women with atypical hyperplasia should be offered bilateral salpingo-oophorectomy together with total hysterectomy. Postmenopausal women with atypia should be offered bilateral salpingo-oophorectomy together with the total hysterectomy. For premenopausal women, the decision to remove the ovaries should be individualized. However, bilateral salpingectomy as the postmenopausal women, bilateral salpingectomy should be considered as this may reduce the risk for future ovarian malignancy as explained before. Endometrial ablation is not recommended because of the same reasons mentioned before. Special cases with endometrial hyperplasia. Women wishing fertility or unsuitable for surgery. Women with endometrial hyperplasia and fertility management. Endometrial hyperplasia and hormone replacement therapy. Endometrial hyperplasia in women on adjuvant treatment for breast cancer. These are 4 special cases to be considered. We start with the first. Women wishing fertility or unsuitable for surgery. How to manage these type of women? Should be counseled about the risks of underlying malignancy and subsequent progression to endometrial cancer. Pre-treatment investigation should be aiming to rule out invasive endometrial cancer or coexisting ovarian cancer. First line treatment for these women is with levonorgestrel intrauterine system should be recommended with oral progestogen as the second best alternative. Once fertility is no longer required, hysterectomy should be offered in view of the high risk of prolapse because there is a atypia. Women not undergoing hysterectomy, they follow up routine endometrial biopsies every 3 months until 2 consecutive negative endometrial biopsies are obtained. For asymptomatic women with 2 negative endometrial biopsies, long-term follow-up with 6 to 12 month biopsy until hysterectomy is performed, until the reason contraindicating hysterectomy is finished or is eliminated. Endometrial hyperplasia and fertility management. Disease regression should be achieved on at least one endometrial sample, not 2 endometrial samples, before women attempt to conceive. Assisted reproduction may be considered as live birth is higher and may prevent relapse compared to women attempting natural conception. Regression of endometrial hyperplasia should be achieved before assisted reproductive technology, as this is associated with higher implantation and clinical pregnancy rates. The third situation is endometrial hyperplasia and hormone replacement therapy. Systemic estrogen only hormone replacement therapy should not be used in women with a uterus, and this is a strongest recommendation. Type A recommendation. All women taking hormone replacement therapy should be encouraged to report any unscheduled vaginal bleeding promptly. Women on sequential hormone replacement therapy preparations and wishing to continue hormone replacement therapy are advised to shift to levonorgestrel releasing intrauterine system or a continuous combined hormone replacement therapy preparation. The fourth special cases is a special case in women endometrial hyperplasia in women with on adjuvant treatment for breast cancer. Women taking tamoxifen should be informed about the increased risk of developing endometrial hyperplasia and cancer. They should be encouraged to report any abnormal vaginal bleeding or discharge promptly. Women taking aromatase inhibitor such as anastrozole, exemestane, and letrozole should be informed that these medications are not known to increase the risk of endometrial hyperplasia and cancer, unlike tamoxifen. There is evidence that the levonorgestrel releasing intrauterine system prevents polyp formation and that it reduces the incidence of endometrial hyperplasia in women on tamoxifen. The effect of levonorgestrel releasing intrauterine system on breast cancer recurrence risk remains uncertain, so its routine use cannot be recommended. Endometrial hyperplasia confined to an endometrial polyp, complete removal of the uterine polyps is recommended, and endometrial biopsy should be obtained to sample the background of the endometrium. Subsequent management according to the histological classification. Here we finish the evidence-based management of endometrial hyperplasia, wishing you all the best of luck and thank you for attendance.